Good morning, everyone, or good afternoon. Once again, my name is Jenny Bogard, and I am the Executive Director here at the National Hypertension Control Roundtable. And I'm so excited for today's fireside chat. We're going to get right to it because we have a very busy agenda over the next hour. So, with that, I'm going to invite our first speaker, Caroline Pearson, who is the Executive Director at the Peterson Health Technology Institute. After her presentation, we will invite panelists up to have a moderated discussion, and we encourage you to type your questions in the chat box as we will be monitoring that throughout the hour. So with that, I will pass it over to you, Caroline.
Thanks so much, Jenny. I appreciate the introduction and I'm really excited to be here with everybody. I'm excited to tell you a little bit more about the Peterson Health Technology Institute today, as well as share recent findings from our assessment of digital hypertension management solutions. The Peterson Health Technology Institute is a nonprofit philanthropy, and we are producing independent assessments of digital health technologies with a specific focus on clinical effectiveness and economic impact of those solutions. And our goal is really to give rigorous and evidence-based information to the folks that are trying to make decisions about digital solutions on a daily basis, whether that be employers, health plans, large health systems that are purchasing these solutions, or providers and patients that are choosing which solutions to adopt and engage with. And as we do this work, we look at a wide variety of published evidence. And we get additionally company-submitted evidence. I'll tell you more about that. And we put it all together into what we hope are very detailed but also easy to read reports that really provide recommendations about how these solutions are working, what their real mechanisms of action are, and ultimately which of the solutions we think warrant broader adoption. So you can find all of the information about this report on our website, phti.org, including additional executive summaries, sort of short pieces for specific audiences, and appendices. But before we get into the details, let me just give you a little bit of background about why we are doing this work. We at the Peterson organization really seek to improve healthcare and make it more affordable and effective for all Americans. And we believe that technology has an important role to play in helping all of us achieve the goals that we have for the health system. We think that digital health is just going to be the healthcare of the future. But we don't think that right now we are on the path to seeing the highest value adoption of that technology possible. When we started doing this work in 2023, we went out, we talked to lots and lots of folks in the market, and we heard very consistently a lot of confusion. We saw big adoption of digital health solutions following the COVID pandemic. Obviously, we've had a decade of significant investment from venture capital and other funders. And so we've seen a tremendous growth and opportunity. But we are not seeing a really consistent connection between solutions that are demonstrating value through clinical effectiveness and the ability to improve efficiency in the system, and their ability to be adopted at scale in the market. And so we are really trying to help solve that, to tighten that connection between really high impact, high value solutions and their ability to grow and be adopted, with clear evidence standards about how digital health companies can be demonstrating their effectiveness. Then we actually do the work to look at sort of categories of solutions and find those that are working the best and have the potential to save money for patients in the system. We then really hope that with that it builds confidence that patients and providers should accept and embrace these solutions, and ultimately that we see a faster adoption on the purchaser side. So how do we do this work? Well, we really start with those purchasers and trying to understand what information they are using to make decisions, given that they're ultimately the ones that are typically purchasing digital health solutions. We're not looking at anything being sold direct to consumer. So we talk regularly with our group of employers, health plans, and providers that tell us really what they want to see out of these reports. And that boils down to sort of the three questions at the right. First and foremost, they want to know, do these solutions work clinically and for which patients? We've seen that as companies are trying to grow, often they're being deployed very broadly across wide swaths of the potential patient population, when in fact, the patients that might get the most benefit out of a solution might be a subset of those eligible, but how do we sort of get the right technology into the hands of the patient that's going to use it and benefit the most? The second big question is, how is this working relative to the status quo? We can't think about digital solutions as a standalone. We have a full, robust sort of environment of traditional care delivery. And so we are trying to understand how digital solutions are layering into other forms of usual care, whether that be adding to the usual care environment, sort of in doctor's offices or in health plans, or potentially substituting for other sources of usual care, or extending access to people who don't have regular access to good care. But we want to be clear about sort of how these technologies are being integrated and then how they're performing relative to other more traditional brick and mortar options. And then for solutions that are driving clinical benefits, we specifically want to understand, do they have the potential to lower costs in the near term over a 1 to 3 year timeline for the employers and health plans that are contracting on that basis, but also longer term to society and the healthcare system at large. And throughout our process, we get a lot of input. We work very closely with stakeholders. And in our evaluations specifically, we have a set of clinical advisors that help us understand sort of what best-in-class care for any of our clinical areas looks like, and sort of how to interpret some of the evidence that we're seeing. We conduct direct research with patients, both to understand sort of what their usual care journey has been like, in this case, as someone with hypertension receiving treatment, and also their experience with digital solutions. We work directly with each of the companies that's included in the reports, and they have an opportunity to submit additional evidence and information about clinical outcomes, as well as sort of commercial information. And then we have teams of health economics and outcomes researchers that help us with a variety of the technical components of our assessments. So with that background, let's dive in to this most recent report focused on hypertension. So as everybody on this call is well aware, hypertension is a huge chronic disease challenge in this country. But one of the things that struck me the most in doing this work is how addressable this condition really is. We've got, about 120 adults in the United States that experience hypertension, and a fraction of them actually are diagnosed and have their condition under control. But what's remarkable is actually that relative to some other areas that are much harder to treat, we have good treatment options for hypertension. Not only do we know what sort of behavior and lifestyle changes in terms of diet and exercise can be beneficial, but we have a wide variety of medications, many of which are generic and relatively affordable, that can be very effective at lowering blood pressure. So as we think about this, we say, well, why are we spending so much on healthcare in the US, and yet we've got so many people going untreated for their hypertension? And that really begins to be a question about sort of the structure of our healthcare system and some of the challenges that lie therein. Particularly what we see is that in busy primary care practices and for patients with multiple chronic conditions, too often hypertension just falls off of the sort of very top of the priority list, right? There may be other more pressing issues that doctors are trying to contend with. Busy practices may have difficulty getting patients back to do medication adjustments and management over the course of the year. And so we really do sort of have a gap between the treatments available to us and our ability to get all of the target patients onto those treatments. And that's where I think the opportunity for some of the digital health solutions that we looked at really begins to clarify. Before I go on, I'll also mention that this is, of course, also a disease that, while widespread and affecting all manner of adults in this country, we do have a disproportionate impact on Black people, on men, and on older adults. And so from a health equity point of view, we should think about how the solutions that we looked at could help improve care and access, particularly for some of those populations. So we conducted an assessment that included 11 different companies that are offering hypertension-focused interventions and solutions. And one of the things that we do is really try to group those companies based on their approach. And it takes a bit of time to sort of think about, every company is a little bit different. Everybody's got their own special sauce, but what are the real themes across which some of these companies are operating? And I'm going to explain that a bit more on the next slide. But here you sort of see our three categories. We've got blood pressure monitoring, medication management, and behavior change as our three categories, and you can see the companies included therein. Each of these companies are offering hypertension-specific modules, and each of them rely on a connected blood pressure monitor at the base of their solution to help patients conduct home monitoring, which of course we know is incredibly important in hypertension care, and then transmitting that data through the app to various audiences, which I'll describe in a moment. As I mentioned again, each of these are solutions that are being sold kind of B2B, so generally to payers, employers, or providers. These are not being sold direct to consumer in their primary mode. And for the sake of comparability, we have included only companies in this group that have raised more than $25 million in funding. Or in the case of something like Ochsner Digital Medicine, if they were started within a health system, they've now launched that in a business and are selling that externally to sort of other commercial purchasers. So let me talk you through how each of these approaches works. First of all, the blood pressure monitoring approach. So these are really solutions that are being sold to providers, to provider practices, and they're billing through the remote patient monitoring codes. And effectively what they do is they help providers to get connected blood pressure cuffs into the hands of their hypertension patients. That data is then transmitted back to the sort of existing care team, often with analysis and sort of alerts to help direct providers to patients that may need medication adjustments or further intervention. But whether or not that existing care team chooses to intervene on a given patient is really going to depend on that provider practice. And therefore, you may have some practices that are very active and others that are slower to respond to some of the data coming in. The second big category is medication management. And these are solutions that are fundamentally different because in addition to the existing care team, they are adding a virtual prescribing team, typically with pharmacists and nurse practitioners, that can really help expand the number of patients that are receiving medication treatment through their existing care team by kind of letting the PCP refer out to this virtual prescribing team. They can do virtual visits to handle all of the medication titration and adjustment, but that patient is still centrally being managed through their traditional PCP. And then the third approach is the behavior change approach. This sits a bit more independently from the traditional usual care environment and from the patient's existing care team. These are really solutions that are taking the blood pressure readings and using them to provide information back to the patient. They may be encouraging the patient to adhere to their medications or to make behavior and lifestyle changes. Some of them have the ability to feed information back to providers, but that's not a sort of mandatory or core component of how these solutions are built. And there is certainly some crossover, but I think this big sort of difference about like where the data goes and sort of how the existing care team is integrated is one of the critical differences. So as we looked at our clinical outcomes, we really focused specifically on systolic blood pressure and decreases in systolic blood pressure greater than 5 milligrams of mercury as sort of a clinically meaningful level of improvement. And then we also looked at the proportion of patients that are in blood pressure control, again, as the sort of two primary outcomes, in addition to a wide variety of secondary outcomes that are shown below. So a busy slide, but let me give you sort of a sense of the results in terms of, and this is looking specifically at systolic blood pressure. So each of these are sort of large comparative studies that compare the digital solution approach to usual care in terms of reducing systolic blood pressure. And the colored bars show you sort of the risk of bias or the quality of any of the given studies. So the purple bars show the studies that have the lowest risk of bias in terms of their study design and execution. And generally what you can see here, if you look at sort of the weighted average labels, is that the medication management approaches reduced systolic blood pressure 7 milligrams of mercury more than usual care, which is a significant improvement. I'll talk you through that in a moment. And also much more than what we saw in blood pressure monitoring, which reduced systolic blood pressure by 3.4 milligrams of mercury relative to usual care. And then the behavior change approach was almost the same, about 1 point of benefit relative to usual care. Now, again, these bars are showing you the incremental benefits of the digital solution over usual care. Because, of course, it's important to remember that usual care, patients that come into care with the PCP that track their blood pressure and may receive medication, also improve. So, for instance, if we look at the medication management approach, we saw that in the usual care arms of those studies, systolic blood pressure decreased by 6 milligrams of mercury. And then in the digital arm, the systolic blood pressure went down by 13 milligrams of mercury as a weighted average, so more than double. And so you really see that those medication management approaches were able to significantly outperform usual care alone. And then that blood pressure monitoring did improve usual care relative to usual care, but probably not as consistently, given that some providers may be quick to act and some less so, as we described before. I know we want to get to questions, so I'm gonna wrap up here, but I just want to sort of give you a sense of how this translates into recommendations. So as you see in the clinical effectiveness column here, we have a green dot. We've got most positive results for that medication management approach, where we saw clinically meaningful and faster declines in systolic blood pressure relative to usual care. Most of those declines were able to be achieved over about a 4 to 6 month period, compared to about a year in usual care. And then more moderate results clinically on both blood pressure monitoring and behavior change solutions. So then we begin to say, well, how much are we paying for these solutions? Each of these categories of solutions increase spending relative to usual care. We're paying for these solutions in addition to everybody's regular visits. But the medication management approach, because of the significant clinical benefits, really does have the potential to offset costs over a decade. And so we do feel that that warrants broader adoption of those solutions, given the strong improvements in population health that they could provide. And so very quickly, I will simply say, I think it was really remarkable to see how really focusing on improving medication management and ensuring that folks who are eligible for medication are able to get on to those drugs and get titrated quickly was very effective. And we need to start to study more about the ability to sort of add additional behavior change approaches to that to improve access. But I think we were excited to see very promising clinical results that really do begin to sort of pay for themselves over 10 years. So with that, let me stop so we can continue our group discussion.
And right before we go into our group discussion, I have two quick questions for you, Caroline, if that's okay.
Of
Um,
course.
is this decrease in systolic blood pressure absolute, or did you control for other factors that can explain the decrease in, in systolic blood pressure?
Uh, Those are well, it varies by study, but they are generally, those are absolute decreases in studies. These are generally studies that have matched cohorts and thus are, and some of them are randomized. You can look at all the details. So the studies themselves have controlled for most of the other variables to the extent possible.
And then another question is for the blood pressure monitoring approach, is the existing care team one of the three companies you listed, AMC Health, HRS, and VitalSite, who then recommend actions to the patient's individual healthcare provider?
No, so those companies are just selling basically remote patient monitoring platforms to the physician. So a PCP practice or cardiology practice would contract with them. That's the software that enables them to sort of see their full patient panel and all the data that's coming in from the blood pressure cuffs. And sort of gives them recommendations on management, but that original doctor is really the sort of one conducting the interaction with the patient.
Great. Thank you. And I'm going to ask you to stay on the virtual stage as we introduce our next speakers. But a reminder that we did put the report link in the chat box. It is public. So if anybody would like to access it, I encourage you to click on that link. And I'm sure Caroline and her team will be available for any follow-up questions after you've reviewed the report. And we're happy to connect you with them. But thank you, Caroline, for that amazing overview of the assessment in Peterson Health Technology Institute. And with that, I'm going to invite some of our speakers to come up. Raul Deo is the co-founder and chief medical officer, chief product officer at Atman Health, and one of our newest steering committee members who will be joining our committee January 1st of next year. He has agreed to moderate this conversation. So Raul, I'm going to pass it over to you and invite up our other panelists.
Thanks, Jenny, for that warm introduction. And thanks, Caroline, for a great presentation. So I have the pleasure of introducing our three panelists. Starting from left to right, I have Vinita Magoon, who's Corporate Medical Director, Clinical Strategy and Analytics, Humana. I have Jim Lee, Executive Director, Global Medical Affairs at Omron Healthcare. And finally, I have Nar Ramakisoon, who is Director, Ecosystem Engagement, American Medical Association. So a nice kind of balanced perspective across the different sectors. And really, just to start things off, based on Caroline's excellent presentation, what do you guys sort of thinking about from the perspective of your organizations, and how are you going to use those findings, or how might they impact the way that you're messaging to your members or your organizations?
Raul, I can start. So good afternoon, everyone. Vinita Magoon. This report was fantastic. It showed that there are several solutions that work. Medication management is more effective than other ones. So that was the best of the three types of solutions that was analyzed. However, it increases net health spending in the first 3 years. So when looking at clinical interventions, I'm usually looking for interventions that show a return on investment within 12 to 18 months. But as I start to think about that in the clinical space, the literature shows that interventions for chronic disease management usually take longer than that time frame. Hypertension is a modifiable risk factor, and it's the leading cause of other chronic conditions and other cardiovascular events that all increase total cost of care. So hypertension naturally would have a longer lead time than other chronic conditions, and it would require more time between the intervention implementation and decreasing utilization, such as inpatient admission. So really, we need to start thinking about hypertension differently compared to other chronic conditions. This report points out that even though medication management solutions increase net health spending in the first 3 years, they have the potential to offset those costs over a decade due to the avoided cardiovascular events. From a payer perspective, that time frame can be really challenging because we don't usually retain members for that long. So that's one of the things that we struggle with. When looking for potential digital health solutions based on this report, I would look for solutions that offered all three interventions, especially since behavior change solutions may help close those access and health equity gaps.
Thanks, Vinita. Jim?
My name is Jim from Omron, and like to have this discussion, very important. First, as mentioned, hypertension is a gateway to a lot of severe disease down the road, strokes, heart attack, heart failure, and name a few. And by the way, the hypertension is also a silent killer. So it is probably not going to make a lot of kind of symptoms initially, but without control, it will make a huge impact down the road. That being said, with this kind of report, with this digital health solutions, it is offer a great opportunities for physicians or clinical team to know the patient's conditions real time, right away, so that they can adjust medications way before the next appointment. Otherwise, it will be a usual care, right? 6 months or 3 months, but now the clinicians can know it right away. And some of the program can also flag, like if the certain patient exceeds the set threshold, and then the patient care program can be adjusted right away. So all that can be bring a lot of kind of benefit for the patients. I also agree that there's a lot of things associated with the so-called patient-centered solutions. So if the patient can get the treatment, do the measurement in the right way, the accurate information flow to the right platform for the clinical team to address, all that will support the winning of this battle against hypertension.
Great, thanks everybody. And I'll just kind of share the provider perspective, being from the American Medical Association. And thanks again, Caroline, and the entire PHTI team for producing this report. Is very comprehensive. And Deb, you did a ton of research, and it really just helps encapsulate kind of all the entire landscape of hypertension. So it is a great, I think, snapshot of the digital health industry and the solutions, and it helps again all those key stakeholders start to think about what are those clinical benefits and those financial benefits. As the American Medical Association, we are really focused on supporting physicians and supporting that patient care. Innovation is a key aspect of this, so we definitely see the value of these digital health solutions in really improving access, streamlining broader workflows, really helping to expand the reach of patient care. When we think about hypertension management, my group, the Improving Health Outcomes group, we're really focused on improving blood pressure control rates, and we understand there's a lot of challenges that clinical teams face, a lot of barriers that they face. So these solutions we're really viewing as like, are there opportunities to remove some of those barriers? Are there opportunities to integrate into the workflows to really support physicians without adding on to any additional burden? So we definitely see great value here as we think about the report itself in the 3 different categories. Not a whole lot was very surprising. I think we've heard from physicians and health systems that medications are really key to improving blood pressure control if we can get the patients access to the medications, if we can get them to adhere to treatment, and if we can get them to follow up frequently. So I think those are all aspects of that medication management that really really drives those clinical outcomes and the financial benefits. I think when you have that tighter connection to the clinical care team, you're going to start to see those results manifest much more quickly. But definitely from a medication standpoint, that's going to be the fastest way to get to blood pressure control. As we think about blood pressure monitoring, there's definitely opportunities here to reach patients that maybe you can't access care quite easily. So there's opportunities to really leverage that technology to bring more folks into that usual standard of care. And then behavior change, lifestyle change, it's in the guidelines. I mean, many millions of patients should get lifestyle change as kind of their first line of treatment. So it's really now thinking about how can we bring those types of solutions into the clinical setting, so there's closer integration, a closer tie to physicians and care team members to really support the patients in making those long-term lifestyle changes. So I think there's a role for each of these solutions. If it would be ideal if we could bundle all of them up and have patient access to all 3 of those components, because they're all guideline recommended. It helps physicians practice, to the guidelines, and that way they're not, mixing and matching kind of interventions and support for different patients that have different types of coverage. So it becomes just a lot more easier if we can get it all in one package, or at least have access to best in breed across these categories, so that we can maximize and optimize the opportunities here for each of these solutions.
Thanks, everyone. So actually, I have a related point that was touched on a little bit. One of the differences, Caroline, between your category A and B is that A, in some sense, is saying, well, the primary care physician is really in a position, or primary care provider is really in a position that they know the entire patient, they know the sort of the comprehensiveness of all the other conditions, so they should be sort of best positioned to do this. Our experience, so just to sort of an aside, is that my company builds software that really focuses on the second model, and really tries to enable a mid-level practitioner reach specialist level decision making, but also let them scale so that it's very, very rapid, somewhat automated decision making, automated notes, automated ordering, so that it becomes very, very economically feasible. And our outcomes are wonderful, but they're also sort of disruptive relative to the status quo, in the sense that it is moving at a different pace, but it sort of seems a little bit threatening to what's going on. And so at the same time as we may discuss how there may be something kind of pleasant about the idea of the existing primary care provider being sort of in the sort of driver's seat for all those changes, they don't have time. And the amount of attention that our model gives is completely at odds with what you can do when you have everything else, you're putting out all these fires. And so how do we sort of reconcile that problem, which is that it's almost like moving towards like a fragmented specialist, ultra-focused model, which is sort of at odds with everything else we've been talking about in terms of sort of comprehensiveness and unified care. But at the same time, from an efficiency standpoint, it seems like this is the only way to go, and that people are just too busy to be able to accord this level of attention. So, put a lot out there, but I'd love to hear the sort of the input there. And then actually one more related point is that to avoid, to reach to Vinita's point, getting to this sort of, ROI earlier on, if we could remove some of the redundancy with multiple people being paid to do the exact same thing, that would be great. But that requires a lot more coordination. Because then how do you separate and say, wait, I don't have to worry about this. I'm not going to have an extra visit for something that I know is already getting done, but that needs a lot more communication. So we'd love to hear sort of all the ideas there might be around these challenges.
Yeah, well, I can lead us off. I think you said it really well, Raul, about sort of what the value prop is. I mean, we all believe that PCP as that coordinator and sort of central point for the patient is important, but they have very finite time, right? And we can't just magically expect them to pay attention to all the things. I think what we see actually in terms of the value proposition to the providers that the medication management approaches are giving is what you described, which is you don't have time to do this. In a given year, let's imagine that you have time to get 100 patients titrated on hypertension meds. We can make that 400 patients, right? And so there's no, because there's such an under-treatment problem, there's actually no cannibalization, right, of revenue or right. We can just get more patients stabilized on meds and treated effectively. And so that sort of ability to scale, I think, is what is so valuable about that second category and what's really driving the results. And then we just need to your point, make sure that we then are not just duplicating visits, virtual visits and in-person visits. There's other ways to create efficiency.
Thanks. So anyone else have any sort of thoughts on the kind of on the provider side? Have you guys kind of run into this? Because I mean, ultimately there are these sort of, the companies are appearing and they're sort of like kind of swooping in and saying, hey, we can do this really well. The existing organizations, it's not necessary that they would embrace that for various reasons. And has that come up at all in terms of any of the sort of discussions that you've had?
Yeah, I mean, I'd agree with Caroline here too, that it's really evaluating these solutions as an opportunity to really be extenders of care as opposed to being duplicative or more complicating factors. So again, from that physician standpoint, not enough hours in a day to do all of this work, and we definitely need to leverage other members of the care team, even other care extenders across these solutions. And there's just good opportunity here to still stay in the loop about your patient, but really kind of delegate things out to other folks that can have the time and the kind of energy to focus on what the patient needs, at time. So I definitely view this as, again, kind of putting around some parameters or requirements on what's going to be useful for the physician and the clinical care team as when they're thinking about some of these solutions. But it has to be, it has to make sense, for everybody, involved, and then still drive the outcome, still, support, quality of care. So there's a lot on the plate of these solutions, a lot of boxes they have to check off to kind of be scalable and sustainable, from a clinical practice standpoint.
Yeah, another input from the manufacturer perspective, the requirement for an institution like the provider to adopt such program is to easily integrate such information into their electronic medical record system. For example, Epic system. So, and as you know, it's a very complicated situation from institution to institution. Even the same Epic system needs some customization. So that is definitely a requirement for the program to be available and to be active and to be adopted by the clinical team, is to make sure the additional information easily flow into the system without a bottleneck, and also can adding some values. For example, now not only you can get information from the patient, you also have those kind of benefit of the threshold you can preset and to see, hey, among that 500 patient, and only like those a dozen people, patient have this threshold exceeding this kind of a level, so that it's red flag, so that clinical team can easily identify and taking action. So all those can help such program to be adopted by the hospital segments, and also how to ease this like insurance bidding process. That is also on the provider's mind.
And adding to what Jim just said, as a practicing physician, we would like to see it integrated seamlessly into the EHR. So not in basket messages where then I have to call someone for a follow-up. I know we still have solutions where we're, getting faxes that lead to paper follow-ups. There are some digital solutions that have come to us where there is a separate portal you have to sign into, and physicians just aren't going to do that. It has to be seamlessly integrated into their workflow, their daily workflow, and their EHR, and the same with their clinical staff.
Yeah, no, and Vinita, I think the point you're making is that it's going to be hard to do that well, because I think that, ultimately, as you have all of these additional kind of billing requirements that are there for you to be able to meet all of those things, then more and more of that time tracking through those additional portals and all those additional features, which are just suddenly, somewhat oppressive in terms of just trying to add to an already busy workday. So actually, I want you to put your pair hat back on, thinking a little bit about this sort of challenge that conditions like hypertension, despite being sort of incredibly prevalent and having that 5 to 10 year sort of devastating consequences, how do we get them on the radar as being something that's a priority? And is it going to be things like Medicare Advantage, where maybe the timeframes are a little bit more stretched out? Or is there a government action that's going to be needed for this to be something of a priority? I'm just curious, how do we get to where we need to be?
Yeah, so we know that there's a couple of quality measures that are related to controlling blood pressure and adherence to blood pressure medication that encourage many payers and also healthcare systems to make hypertension, hypertension management, hypertension a focus. We know our public health system has also prioritized hypertension with national campaigns. And recently, FDA even issued voluntary sodium reduction targets for manufacturers of processed foods, because we know that dietary sodium is a leading cause of hypertension. Yet, as this report shows, we still have millions of Americans with uncontrolled and undiagnosed hypertension. I honestly think in order to make hypertension a national healthcare priority, it also needs to be a priority for patients, right? Patients need to understand you know, what does high blood pressure actually do? I often see patients coming in and saying, I have high blood pressure, you know, I just need to get on my medication, but they don't realize, speaking to what Jim had said earlier, that it translates into other chronic conditions such as stroke, heart failure, you know, MI, CKD, even dementia, and they don't always make that connection. So how do we help patients make that connection? And honestly, it's through behavior change, it's through education, and then communicating this information to the PCPs, because the PCPs don't have the time to do all of that patient education. So we have to help them, and I think that's where digital health solutions would be really valuable.
Caroline, could I ask a question? So you guys, you know, it looks like you have your institution has sort of a broader mission around digital health tool evaluation. How did you guys start with hypertension? What was it about it that made it sort of appealing as a condition to study?
So hypertension is the third condition that we have assessed. We started with diabetes, then we did virtual musculoskeletal solutions, and then hypertension. So, you know, at the beginning in our first year, we've been hitting really sort of like large disease areas, right? High prevalence and big share of spend. But these are also some of the areas where the digital health solution market is more mature. So, you know, these are some of the oldest solutions on the market. They've had a lot of time to both refine their business model and generate evidence. So they're sort of eminently accessible. One of the things that is really different in hypertension relative to, for instance, diabetes, is actually the effectiveness of treatments available. So, you know, unfortunately, usual care options for diabetes aren't great, right? We're not great at reducing hemoglobin A1Cs in people with diabetes in any environment. So those solutions, it was much harder to, right? We didn't see digital solutions changing that paradigm. What's so interesting about the hypertension space is we do have effective treatments available, right? And we're really just under treating wide swaths of the population. And that's a place where digital solutions can play a very important role at, you know, scaling, improving access, and reaching a variety of underserved populations. And so this was a much more promising report in that sense, because we sort of can have a thoughtful way to use digital solutions to solve gaps in traditional care.
Yeah, I think the other point that you had made earlier was that the majority of medications for blood pressure treatment are generic. You know, diabetes, the sort of the amount of prior authorization sort of work you have to do on top of everything else is quite sort of forbidding. But here, that's generally not a problem, and that most of these are accessible. So that does certainly make a contribution for its, well, seemingly it should be feasible, and yet the statistics are sort of what they are. Thinking again about sort of some of the challenges of turning this into a sort of more of a reality. Is there a collaboration on the payer provider side that could make sense in terms of how to accomplish something like this? And I said that sounds a little bit naive in terms of saying, you know, why can't we all come together and figure this out? And I think Vanita's your point about patients having to recognize this is, I think, a huge thing. And you know, just think about the difference between this and GLP-1 demand, and you realize that as soon as something is at the forefront of something that patients want, then all of a sudden things start to move. And so, you know, let's bring the tripartite solution, then the patient, the payer, and the provider. How is it that we can kind of come together to sort of accelerate this? Because there's certainly, it's not as if people haven't tried. What's the path forward, and what's the digital catalyst here too?
Yeah, so I want to put on my physician hat and say I want to start by saying that we've come a really long way from the previous ways of checking blood pressure outside the clinic. I can think back, 15, 20 years ago, if a patient had a blood pressure that was not under control and the patient didn't have a blood pressure cuff, I would tell them to go to Walmart, or I'd tell them to go to a grocery store that had a pharmacy and use that blood pressure cuff several times a week, write it down on a piece of paper. It was typically a napkin, and they would bring it back, the next week if they showed up. We've thankfully moved past that because that added so much complexity for the patient and it made it harder to engage the patient. Digital health solution interventions can provide physicians with an opportunity to kind of close that gap and get that piece of clinical information. So we are able to receive ambulatory blood pressure readings outside of the office and at different times of day, which is really valuable for us. So as a practicing physician, that's what I'm really excited about. But on the payer side, before we deploy an intervention, we need to make sure it makes financial sense from a cost of care perspective. So yes, the intervention may improve health outcomes, but how does that translate into savings from the health plan? Does the improvement in outcomes directly correlate to a reduction in inpatient admissions, going back to utilization? Does the digital health solution have literature to support this, preferably an internal study that uses similar populations? The report actually looked at 11 companies. I thought this was really interesting, and only 6 submitted evidence for review. And we face similar struggles when trying to get evidence from digital health companies to show their financial impact. And it's not that we don't want to partner with them, but if we can't show evidence of financial impact with their model, then we can't move forward. So what we usually find is that cost savings from the decreased utilization, if that link can even directly be made with that intervention, do not offset the cost of the intervention itself.
Yeah, and I'll just kind of add to it. Vinny's make some great points. It's hard to align kind of the incentives for everyone here. So it almost needs to need to rethink the model a little bit. Like, in what model would kind of all parties benefit here: the patient, the provider, and the payer, with maybe the digital solutions kind of in the middle, helping to drive and find the efficiencies, find the cost savings over time. So whether that's value-based care or some other type of subpopulation type of a model, I think that's worth exploring. I do also agree that transparency by the digital solutions is very important. I think from everybody's perspective, the more information that we can get around the effectiveness and of some of these tools, where they've been used, under which populations, which clinical practice settings, all those are all variables that we need to get considered when trying to make a purchasing decision or a payment decision, because that's not necessarily replicable for different populations, or when you start to think about scale. So lots of I think factors coming into play here, but I do think that there's a great opportunity to, if we just think of it from a guideline perspective, we want to support providers to practice to the guidelines. So if digital tools can make that a little easier, make that maybe faster, then maybe we'll start to realize some benefits for the other stakeholders as well. But I think kind of adhering to the guidelines could be a great starting point as we think about a model that can be deployable across the board here.
Also, from insurance point of view, like CMS actually has a rule about the coverage for the remote patient monitoring. The requirement is for 30 days. You need to have at least 16 days data collection to be able to qualify for reimbursement. So for private insurance company, probably a similar rule will be there. Why such rule in place? Because we touch on a very challenging factor, which is, in this case, is a human behavior. So for patients, even with this cutting edge technology, patient does not necessarily always compliant to a daily measurement and then have the information feed to the clinical team. So what if they just measure 10 times a month? Then such patient, the cost is not going to be reimbursable by the CMS, right? So all that factors need to be considered. How to design a system patient-centered, but also patients need to be aware and empowered so that they can act on the information outflow. For example, the measured blood pressure on a daily level, so the information can flow to the clinical team. And then they also need to take the medication, which is prescribed, and fill the medication so that they can take this daily, not skip. Because from our practice, we saw that some other blood pressure you can see bump up, and then it means they either skip the medication or take it wrongly. So all that need to be also into the consideration to achieve the best outcome for the patient, as well as for the providers and insurance. So it's all factors need to be in one plan so that it is not an isolated kind of a plan. So this is the kind of what we observed to be considered to be a more effective.
Yeah, our company's experience has been that there's nothing like watching that blood pressure come down in response to frequent medication changes to motivate you to want to measure more. All of a sudden, the equation just changes, and so you have people happily enjoy it because they just watch things getting better. I mean, I think we found two things. One of them is frequent sort of short calls with changes that result in improvements, and somebody willing to listen about side effects and willing to sort of make a change in response to that, and not sort of be monolithic and sort of insist on something being there. I want to get back to something that you mentioned, Caroline, which is the idea that perhaps there may be subsets of patients that might be of greater benefit. And maybe that is the alignment where you get sort of that's the to use the startup speak, a little bit of the land and expand sort of thing, is that there are a group of them where the model is accepted, there's an enthusiasm for it. Providers see that there's some benefit to potentially sort of, letting a remote team do this at much, much more efficiently, and that there's an economic case to be made in a shorter time frame. Did anything emerge from any of the analyses that you guys have done that sort of points to where that might be?
Yeah, that's a great question. So, I mean, one of the things is we've done this work across clinical areas. One of the places that people are most excited about digital solutions is trying to close access gaps, reach underserved populations. In past reports in other clinical areas, there has been much discussion about underserved populations and very little evidence actually testing solutions in those patient populations. We were really pleased to see that in hypertension, actually, there were many, many studies in our report that really specifically looked at diverse racial and ethnic groups, low-income populations, predominantly Medicaid populations, rural groups, others that have access barriers. And so there was a real priority to see sort of how these solutions worked. A few interesting takeaways emerge. One, the positive news was across groups, each of these solutions worked quite well, worked sort of consistently well, right? So from a engagement point of view, they were able to engage and successfully, deliver clinical benefit regardless of sort of some of those differences across patient populations. But what was important is what you see is in underserved groups, both patients receiving usual care and those receiving the digital solution saw big improvements in their hypertension outcomes. And so what that tells you is hypertension is a big problem for underserved groups. They have some of the highest starting blood pressures. They have the most benefit if you get them into effective treatment. But that the digital solution is not a replacement for usual care, right? So if we have a population with high starting blood pressure and poor access to usual care, and we give them a digital solution that maybe gives them behavior change recommendations, that's not a substitute for a PCP who can get them, onto meds with any help, right, and get them stabilized effectively. And so we just need to be clear-eyed about both the potential to scale access with a digital solution, but not that it's a replacement for any sort of traditional care. And I think that came across clearly in this report.
Raul, you're on mute.
Yeah, sorry, Jenny, are there questions that we should take from the audience, or do you think we should do closing statements from
There are a few questions. I have a quick one. What's the current utilization of patients who have access to one of these digital management options as part of their insurance? Do we know the answer to that?
Sadly, that is a common question. I can't answer it in almost any digital area. So unfortunately, I don't know sort of what % of patients. I will just on the question point out one distinction in these groups, right? The behavior change solutions are the ones that are predominantly being sold to health plans and employers, whereas actually the blood pressure group and the medication management group are largely being sold to providers. That, of course, gets reimbursed through the insurer, but the insurer isn't necessarily giving them access. So I don't know what % of provider practices are using some of these solutions as of yet. I would say still a small amount.
So I think with interest of time, we'll get to closing statements, but for the panelists, there are lots of comments in the chat box, and we might want to answer some of the more specific questions offline, but I'll pass it back to you, Raul, and all the panelists for closing remarks.
So thanks everybody. Would be great to sort of hear some final thoughts from everybody in terms of putting together what we've heard and maybe hopes for the future as to what we might see in the next year or so that might sort of suggest a change or something, some catalyst for why we might see something that's a change in the direction we want it to go.
I
Yeah,
can comment maybe. Go ahead.
Jim, go ahead.
Yeah, I want to emphasize on the importance of empower or engaging patients, because a lot of things, as I mentioned, is patient-centered. Patients are the information provider, but also they are the action taker. So it's so important for them to be fully engaged, empowered, so that they can reach this hypertension control. The second point, quickly, is about the patient need to have the validated blood pressure monitor to ensure the blood pressure readings are accurate and trustable. The third point is the patient also need to have the right knowledge to how to measure blood pressure, because that is the kind of things a lot of doctors or care teams neglected. For example, patient need to be sitting quiet and need to not get bothered or distracted by the cell phones, and they need to be like in the proper position to take blood pressure readings and not to move during the measurement. So all that is critical, because if not taken that precaution, then the blood pressure readings won't be as trustable, and then decisions can be wrongly made. And finally, I saw one of the questions in the audience is about how to deal with white coat hypertension. Actually, the beauty of this digital health solution is you measure the BP at the home and you avoid the white coat hypertension, otherwise measured in the clinics. So this is actually an advantage for home BP and remote patient monitoring.
Thanks, Jim.
Yeah, and I'll add a little bit on to what Jim had mentioned too. Really starts with that, physician-patient relationship. So if, the digital health solutions can be seamless, can really support that relationship and help engage, the patient. I think that's where we're going to start to see a good foundation, to build off of. And again, there's 3 approaches that were in the report. The foundation of those is home blood pressure monitoring. So we do want to make sure that that is done properly as well. Use of a validated device that Jim mentioned. Use of an appropriate size cuff, for the patient. Ensuring that they're following an appropriate measurement protocol. So measuring BP once a month isn't going to cut it. So what kind of frequency is going to be appropriate to get a true average of a patient's blood pressure, and then a mechanism to get that information back to the physician. So that's just from a foundational point of view. I think we still have a long way to go, digital, non-digital, on home blood pressure monitoring. So we want to make sure that there's a good standard there, a high standard of care, and then if solutions can build on top of that, depending on which aspect they want to focus on. I think that's going to help again, lead to a lot more successful results and sustainability.
And one last point that I want to bring up, digital health solutions for hypertension seem promising, but I think there's 2 key processes that have to be in place. Medication management that's based on delivered data. So does the PCP get the data, or is the virtual care team taking care of that data, but also communicating that information to the PCP? And then direct communication with the PCP. So even though the goal here is to help the patient, we want to avoid PCP or provider abrasion. And sometimes a third party who's not fully integrated or transparent can contribute to that abrasion. So we want to keep that in mind as well.
Any thoughts, Caroline? Or
No, I think I've said my piece. I really appreciate it. I think this is a great example of where the technology can really plug in thoughtful ways to our existing care environment to create scale and access. And I am glad to be able to sort of help drive towards the solutions that are more effective in this space.
wonderful. Jenny, do you want to close?
Yes, thank you. Well, thank you to all of our panelists today for an amazing conversation. We will continue this dialogue with additional fireside chats in the new year. But in the meantime, I wish you all a festive and happy holiday season. And I hope no matter where you are, you can spend it with those that you love. So thank you, everyone, and we'll see you in 2025. Have a wonderful day.